What's up everybody, Dr. Rossi, welcome back to the channel, and today's topic is going to be one of the best ones we've ever done. So we're going to be talking about understanding why depression is not just depression, and you'll see what I'm talking about in the video here in a second. Now before I get into all that, if you're new to this channel, please consider subscribing to the channel and liking the video. It really helps me to continue making these videos, and if you're a returning viewer, thank you so much for all the love and support. As always, it means a lot to me. Now today's topic, like I said, we're going to be talking about understanding why depression is not just depression. So there's a problem in psychiatry, and that problem goes something like this. When we classify people as having quote-unquote major depressive disorder, we're lumping many people into the same category who may not have the same underlying reason for their depression. Now you know that I've been critical of the DSM criteria in the past and said that this is like not a Bible, this is more of a rough guideline. Yes, the symptoms are important, yes, they're helpful, but they don't tell the whole story about the disease process itself. So what winds up happening in most of these cases is we have many people being diagnosed with major depressive disorder, resulting in them all receiving the same treatment, namely some form of psychotherapy like cognitive behavioral therapy, or a medication like a serotonin reuptake inhibitor, or an SNRI, a serotonin norepinephrine reuptake inhibitor. So one of these type of medications is usually prescribed. Now to truly understand depression, we need to understand a lot more than the diagnostic criteria. And that's because there are many ways one could meet the criteria for major depressive disorder as defined by the DSM-5. So we're able to see that there's many different situations, circumstances, that somebody would meet these criteria and be diagnosed quote-unquote major depressive disorder. Now the symptoms described in the DSM represent a range of conditions in my opinion and in other experts' opinions, and tells us very little about what type of depression the person might be dealing with, and it also makes it difficult for us to choose the treatment that will be most useful. So today's topic is going to cover why depression is not just depression. Okay guys, so before we dive into the various types of depression, I want to first talk about the history of how major depressive disorder became a diagnosis in the DSM to begin with, because this is very important. This is how the selection committees for DSM make these decisions. Now, I'm coming to this from the basic argument that major depressive disorder actually encompasses many conditions and may lack scientific validity. So we can argue that the failure of trials like the STAR-D trial, often quoted as saying that people who start antidepressants, only 33% of them achieve remission when they start antidepressants, maybe the reason behind that is not so much that the medications are ineffective, maybe it's because the diagnosis of major depressive disorder is too broad and lacks scientific validity. So this is just something to get you thinking, right? Is it possible that the medications do work as long as you select the right type of depression to use medication in? Now, major depressive disorder ended up being a construct of the DSM-3 committee. So we're on DSM-5 TR now, the text revision, and this is going all the way back to the 1980s and DSM-3. So they wanted to replace the psychoanalytic concept. So psychiatry was moving away from psychoanalysis as an explanation for pathology and moving more towards biological explanations for psychiatric disease. And they wanted to remove neurotic depression or neuroses. They wanted to remove neuroses from the diagnostic criteria. And they proposed this idea of proposing a minor depression. And the reason they wanted to do this was, and the reason this was controversial is the psychoanalysts wanted to keep neurotic depression or neuroses as a diagnosis because that was their major billing diagnosis. They mostly saw patients with neuroses, quote unquote. So they wanted to keep it. The proposal was to start something with, that was to go from neuroses to minor depression. However, this didn't work out, and there was pushback again from the psychoanalytic practitioners because they felt that if something was called minor depression, then they would be reimbursed in a minor fashion as well by the insurance companies, for example. So they didn't want to do this. So what we got instead, what the settlement was, what the ultimate decision was for the DSM-3 committee was to create this diagnosis of major depressive disorder And then we also got this other new diagnosis, generalized anxiety disorder. And you can see, if you look at the criteria for both of these, that there is significant overlap in the symptoms between major depressive disorder and generalized anxiety disorder. And this was more, what I want to stress to you about the history of this is that this was more a political and professional compromise than it was a scientifically valid change in the DSM, and it persists largely unchanged to this day. So we need a new way of thinking about major depression and maybe thinking about depression on a spectrum. Now, a lot of this information comes from Dr. Nasir Gami, who is a very well-respected psychiatrist and one who's really helped shape a lot of my thinking as well in psychiatry. Certainly would recommend reading his stuff if you get a chance. So what can we do to think about this differently? So in place of major depression, what we can start to do is we can break depression down into 4 unique categories. So when I think about this, I think about these 4 categories of depression, and I try to take examples from my clinical practice and say, okay, this person would benefit more from this type of treatment or that kind of treatment, depending on what type of depression they are presenting with. So this really helps you to make treatment decisions as well. So on the more chronic but mild end of the spectrum, we have what we're going to call neurotic depression here. Then in the middle, we're going to have our pure depression, which is largely a diagnosis of exclusion, and I will explain to you what I mean by that in the coming sections. We also have the mixed depressive episodes, which are very important, and they might be as high as 50% of the depression cases that we see. And we can look at the more episodic but severe cases of, say, melancholic depression on the severe end of the spectrum, but also, again, episodic, not chronic. And we'll cover each one of these in detail in the subsequent sections. So let's start on the mild chronic end of the spectrum with neurotic depression. So these individuals are going to be patients who present with a baseline mild to moderate depression and anxiety that is more persistent and chronic. Now, if these individuals were to see most psychiatrists who are doing their DSM-based diagnostic criteria, then what they would get is these individuals would normally be diagnosed with some combination of major depressive disorder, generalized anxiety disorder, and also persistent depressive disorder. Now, what we need to understand about neurotic depression is that it's typically less severe and there are more anxiety symptoms. This is very important because it's going to help separate some of the other ones that we're going to talk about in subsequent sections. So less severe, more anxiety symptoms, and they are marked by significant sensitivity to psychosocial stressors. That's also important. These individuals are very susceptible to being tipped into major depressive episodes as a result of psychosocial stressors. So when something's going bad in their life, they have a tendency to tip briefly into these major depressive episodes. But what we have to understand here is that it's not the major depressive episodes that they tip into briefly that are a problem. It's the chronic mild to moderate anxiety and depression that is persistent throughout this individual's life. So again, briefly, they are easily tipped into major depressive episodes, but these episodes are very, very short, and they can just as easily return to their chronic mild to moderate depressive and anxiety state without much issue. Say there's the psychosocial stressor is removed, for example, the person tips back into their chronic mild to moderate anxiety. And again, the problem with these individuals is more so that they're going to have this chronic mild to moderate anxiety state at all times. And the other issue that we run into often is that these individuals are not very good candidates for your serotonin reuptake inhibitors, for example. They don't usually respond very well to medication. And that's where, again, this treatment decision is you're starting to see how treatment decisions are going to be made based on these classifications. So let's move to the next category, and I'm actually going to jump to the end, and you'll see why in a second, because the ones in the middle, the pure depression and the mixed depression, are important to discuss, but we should first understand the bookends of these 4 categories, being initially the neurotic depression, the chronic mild to moderate anxiety and depression, versus what I would term here melancholic depression. Now, this is a severe type of depression that not only is severe, but it's episodic, and it's generally not associated with anxiety. This is something people sometimes don't get. Many people present with depression and anxiety together. So when you're seeing these severe cases, you're looking for the absence of anxiety, and you're looking for a course of illness that is severe and episodic. Now, the key clinical symptoms of melancholic depression include severe psychomotor retardation, so very slowness of movement, but also slowness of thought. So when we're talking about psychomotor retardation, we're talking about both slowness of movement and thought. That's important to remember. And of course, these individuals have marked anhedonia, also known as loss of interest in pleasurable activities. So what usually is most compelling about these individuals is their complete lack of mood reactivity. That's very important too. So these individuals have an absence of mood reactivity. And what I mean by that is when something good happens to this individual, they have no response to it. Their mood doesn't change. They don't become happier temporarily because of that good event. And when something bad happens, they also don't become upset by it. So the way we can kind of think about this is they're completely unresponsive to psychosocial stressors, good events and bad events alike. Essentially, for example, you might say, well, how come this person can't get more depressed because of a bad psychosocial event? No, because these bad events can't make them feel any worse than they already feel, right? They're severely depressed to begin with. Now, the depression in these cases is severe, it's dangerous, it carries a very high risk for suicide. So rapid treatment is often required for these individuals, and it can take the form of antidepressants or electroconvulsive therapy or some combination of the two. You could probably toss in some other things like potentially TMS, transcranial magnetic stimulation, as well. But the important point here is that this is a severe episodic depression that requires immediate treatment because of the high risk for suicide and because of the severity of symptoms, and that this is one of the types of depression we're going to talk about that is very responsive to treatment, which is a good thing. And again, the traditional treatments that we think of when we're treating major depressive disorder, such as antidepressants and electroconvulsive therapy. Okay guys, so let's talk about mixed depression, which I think is one of the most important parts of this entire talk because it's quite common and the treatment is significantly different than what you would do for a pure depression or what you would do for a melancholic depression or even a neurotic depression. So the current DSM classification for bipolar disorder as well as major depressive disorder with mixed features in the DSM allows patients with 1 to 3 symptoms of mania to be diagnosed as major depression. And this can create a problem because some people suggest, and some studies suggest, that 50% of patients who present with a depressive episode actually end up having a mixed episode, being 1 to 3 of these manic symptoms. And in my opinion, manic symptoms always matter because, again, they change the treatment course. They change the recommendations that I would make for a patient. Now, studies have indicated that significant benefit can be found with things like lamotrigine, again, mood stabilizing agents first, lamotrigine and low-dose lithium, as well as the dopamine blocking medications. So again, these agents work well in mixed states. They might not be your first-line option for a neurotic depression. They might not be your first-line option for a melancholic depression. But here in these mixed states, these things really shine as treatment options. Likewise, the antidepressants do not show the benefit that we would hope for. Antidepressants are known to be mood destabilizing, and they can actually make these mixed states worse. So being careful not to prescribe antidepressants to people who are in a mixed depression. The core features of mixed states include things like irritability, agitation, and a labile mood. The original concept of manic depressive illness did not separate poles. So before the DSM started separating bipolar and unipolar depression, the original concept of manic depressive illness did not separate the poles, and probably for good reasons. So for example, an individual who's had 100 episodes of depression would be considered manic depressive, right? Would have a diagnosis of manic depressive illness. And likewise, an individual who had 10 episodes of mania would still have the same illness, manic depressive illness. And if you stay tuned in the future, I'm going to have a video next week regarding all of these details. And it's going to explain this mixed concept a little bit more in detail because I think it's so important in modern psychiatry. Okay, so let's wrap things up with the pure depression. Now, I said before at the beginning of this video that pure depression was a diagnosis of exclusion, and I'm going to tell you what I mean by that now. So some depressed patients will retain some mood reactivity, they're going to retain some interest, and are going to be somewhat functional. So these are like a so-called high-functioning depression, right? These individuals will meet DSM-5 criteria for depression. They will have no manic symptoms, and they will have little or no anxiety. So this is very important again, and what that's helping us to separate, as you can see here, is the categories, right? If there's no manic symptoms, then they can't be mixed depression. If there's no anxiety, then they're not going to fit into the category of neurotic depression, for example. Their course of illness is usually episodic in nature, and their mood is euthymic or normal in between episodes. So it's an episodic course where the person's mood is normal in between these episodes. They're not melancholic, they're not mixed, and they're not neurotic. So they don't fit any of the other categories. This is also a group that would respond well to medication, again, because it's more of a quote-unquote pure depression. So things like serotonin reuptake inhibitors can be very resourceful in these individuals. All right, guys, so I'm going to hold the video there, and I would love to see your comments and questions below because I think this is such an exciting way to think about depression and one that we should be doing more often as clinicians, right? We should not just be blindly following criteria laid out in the DSM without trying to really understand what are the underlying and driving causes of depression for our patients. We want to help ease patients' suffering, but we want to do so in a safe manner, and we want to be selecting the most appropriate treatment for those individuals. So I think what this categorization helps us do is really sort out who benefits more from psychotherapy, say your neurotic depressions, who benefits more from medication treatment, say again your melancholic, severe episodic, high risk of suicide individuals, and then who requires more mood stabilizing agents or dopamine blocking medications for those individuals in the mixed states. So I think this really helps us to conceptualize depression in a different way and start to think about it in a more resourceful way that's not only going to help you as the clinician potentially, but also help our patients. So that's it for today, guys. Thanks so much for watching. If you haven't already liked the channel, or subscribed to the channel rather, and liked the video, then please consider doing so. It really, again, helps me to know that this stuff is valuable for you. So take care until next time.